I do have experience working with children from ages 2 till up to 16, and I've personally worked with children who talk, who don't talk. I've taught them communication. So I just today's presentation is just to help you all about challenging behavior and some topics to discuss there. So we have a new book, which is technically, like Lauren will put it, our Bible. It's our textbook for behavior analysis. It's the Cooper, Heron, and the Heward book. It's a 3rd edition. And they've actually redefined ABA. So it's a little different from what we studied. It says it's the science in which tactics derived from the principles of behavior are applied to improve socially significant behavior, and experimentation is used to identify the variables responsible for improvement in behavior. I guess they put experimentation because behavior analysis is a science. So all the information or principles come from research, and that's why they put in the word experimentation in this definition. Okay, and so always there are some myths about ABA because people have their own views, and some of them are, rightly so to have your own views. But I'm just going to quickly go through these. That ABA is dog training, and it's not appropriate for people. Actually, dog training is very different from ABA. I don't think we could apply our principles to train dogs. There's a whole different science in that. ABA always requires food reinforcers, especially candy. That is not true. Children taught using ABA are rote responders who simply memorize responses. Children taught using ABA do not acquire skills that are functional and generalized. We have taught children in our setting, and they have generalized to different providers. They go to school. We just recently had a child who is graduated and going to school with no label. So clearly he's learned to generalize and has used functional skills too. ABA is harsh and focuses on aversive control. ABA is only discrete trials. ABA requires too much manpower to be used in schools. So yes, I've just worked in a clinical setting with one-on-one therapy. I have never worked in a school district, and I understand the student-teacher ratio. But this point says that we can all use the principles of ABA and teach our children. So yes, as one-on-one is beneficial and would be helpful, but it could still be used in a school setting. A child must be at a certain developmental and skill level to benefit from ABA. Honestly, I believe that all children can be taught. So yes, there may be some who are very early learners and some are high functioning, but we can teach all children. So they do not have to have a certain skill level to learn or to get ABA services. Children with behavior problems are not good candidates for ABA. They are the best children, the best candidates in my opinion. ABA doesn't address relationships and socialization, and ABA doesn't work for some children. Applied behavior analysis works for everyone, even grown-ups. So that's something that I think views are changing, but these are still some myths because it works on neurotypical children, it works on grown-ups, and the principle of behavior analysis is applicable to all of us. So some factors to consider when we teach students with autism. One is the lack of appropriate communication. Most of the children that we get at the center have very little communication. And the reason they are there is because the communication is poor. So that is one of the places to start, teaching communication. Lack of social understanding and awareness. Sleep issues. A lot of our children do have sleep issues. There could be GI problems. Some could have sensory needs. Unusual responses or lack thereof to stimuli in the environment, over or under generalization. So this could be a situation where you teach a child to greet people in a setting, and then they go to a mall and they see strangers and they start saying hello to everyone without that awareness. So that would be generalizing. Unusual fears, obsessive adherence to rituals and routines. A lot of our children do have these behaviors. Changing a simple routine for them is very difficult and challenging, and we would see problem behaviors associated with that. Repetitive behaviors, seizures. It is kind of interesting. I have read some articles where as children reach adolescence, there seems to be sometimes an increase in seizures around puberty. Of course, being autism being still something that is continuously being studied, but knowing that it's a neurological issue, it kind of makes sense that during puberty, your body's going through so many changes, but we see children who do have seizure disorder, or seizures become more common at that age, and aggression and self-injurious behaviors. So how do problem behaviors develop? These are 4 important or main reasons. One is inconsistent expectations. As we all know, a child comes to a parent saying, "Mom, I want candy." Mom says, "No candy." Child will go to the dad. But dad may give candy. So just these inconsistent expectations, whether it's in the home, it's in the center, it's at school, and there could be problem behaviors. There could be health issues, like I said, GI issues, sleep issues. Obviously, if the child is not sleeping well, they're going to come to school. They don't want to do work. They're going to cry or scream, and that could cause problem behaviors. Special needs. Some of our children, besides being on the spectrum, may have physical disabilities, and that could be a reason too, and skill deficits. So here are some of the reasons for reducing problem behaviors. Problem behaviors often increase over time. Behaviors that you may think are minor at the age of 3 could become severe problem behaviors by the age of 10. So right now you may have a child who's 2 or 3 and just crying. The older the child gets, the crying could become more intense. Or if they're just, you may say, "Oh, he's just grabbing me." The grabbing could become into scratching or pinching as they get older. Also, you kind of want to remember your child is physically going to grow larger. And as they grow larger, they're going to have more energy and more strength, and the problem behaviors are going to get intense. The older the child, the more difficult it is to produce consistent long-term reduction of serious problem behaviors. So if it is going to take you 30 minutes to get your child to do a puzzle because he's crying right now, over time, as the child grows older, all these years of where the problem behavior has been reinforced, it's probably going to take you much longer to get your child to do a small task for you. Because in the past, you've let your child cry and escape the task that you wanted the child to do. Children who engage in problem behaviors may be less reinforcing to work with. It does get very challenging for professionals to work with children who are engaging in problem behavior, because some of it can be very severe. So as much as we love our population and we love working with children, I mean, it could get physically challenging for providers. It could also be very mentally challenging for them as the child gets older. Engaging in problem behaviors will ultimately result in reduced quality of life for individuals who engage in such behaviors. So just a simple scenario. You're at home, you've tried to work on eating together, meal times, you've run into trouble, the child eats and then wants to leave, and that has been the norm in the house, which is okay. But as the child gets older, you want to go to a restaurant, and the child wants to eat and leave, and you say, "No, we're going to sit at the table." But now you have either self-injurious behavior or screaming or crying. It really affects the quality of life of the entire family. And that is why we want to work on these at a younger age. But these are some of the reasons that we hear is like, my child has autism, a disability, or developmental delays. So that is why they're having problems. But all these problems need to be worked on, or at least addressed as the child is at a younger age. So the 2 big issues that we sometimes deal with is aggression and self-injurious behavior. First and foremost, we're always looking at the safety of the people who are implementing the behavior plan and the child. So it is not just about us, the providers. We want to keep the children safe too, and that's the first thing you want to address. So just always remember, whether your child is going to a speech pathologist or is in the school district or is going to a center, their safety, especially where we work, the safety of the child is the most important thing, but also the safety of the provider. You want to consult a professional to get professional help, and you want to avoid physical restraint if at all possible. I know this is, we at where we work, we really don't do restraint. We use bean bags to protect ourselves and the child. And I know that districts have different policies, so I'm not going to go into that. But you do, even at home, there are ways to protect your child and yourself without using restraint. So often problem behaviors, so we're going to look at the analysis. I wouldn't say most often, people look at the form of the behavior or what the behavior looks like. So you may have heard or seen of this: hitting people, biting, crying, screaming, running away or elopement, throwing things, breaking things, kicking, looking away, not responding. Let me tell you, I've seen it all and more, and experienced it all too. The function, though, is what is causing the problem behavior and what is maintaining the problem behavior. So you have a form, or what we call the topography in behavioral terms, and then you have the function. What was the original reinforcer for the behavior and what continues to reinforce that behavior. So as behavior analysts, we actually look at the function of the behavior. Sometimes I have had a child do a task and they're crying because it's difficult, they don't want to do it, and a few minutes later they start laughing. And you may have seen that too, or heard of it. And then I have a parent saying, oh, but it seems that what you're doing is not working, the child is laughing. The topography does not mean that the function, it has no connection to the function of the behavior. The function is the same. I'm telling the child to do a task. It's difficult. They don't want to do it. They're just going to try to find a different way of behaving so that you as an adult may think, okay, this is fun. I don't want to do this. We see this often during toilet training when we're doing positive practice. We are taking the child back and forth to the bathroom, and suddenly the child is laughing. They are not enjoying this. They are just using a different form for it to look different so that they actually try to trick us. So you do want to focus on the function of the behavior. So the function would be analyze the problem behaviors according to their function rather than their form, and planning behavior reduction procedures according to the form rather than the function may actually lead to increase in problem behaviors. It is not always easy to analyze the function. It can be simple, it can be challenging because, in my opinion, sometimes there are two functions to the problem behavior, so it's not very clear. But you want to try to analyze it by the function the best you can instead of the form. Lauren, sorry. So we use what is called a three-term contingency. You have an antecedent, a behavior, and a consequence that's going to change the behavior. The behavior in this is always the behavior of the child or the person behaving, of the behavior, and that's what you're looking at. The antecedent is the stimulus, is what occurred before the child engaged in a certain behavior. The consequence is what happens in the environment, or what do you do as an adult when that behavior occurs. So if you can look at a certain behavior and try to analyze it like this, at home, even as parents, you will have a better understanding of why your child is behaving in a certain way. It is a really simple strategy to use. You just look at what happened, what you did before. I asked my child to put on shoes. Child is screaming, crying, but I'm getting late to go to the mall, so what do? I put the shoes on, and that's the consequence. In the future, when you go ask your child to put on shoes, you're probably going to get the same behavior because now the child is like, oh, mom's going to do it. Why should I do it? So you just want to try, and as simple as you can, try to analyze it in the moment if you have time, and hopefully you will know what is causing the behavior to occur. So here we come to how do I change the environment? We look at interventions and the consequences. So like I said, there will be consequences to a certain behavior. You really want to look at the antecedents. And that is something that I can't emphasize enough the importance of using as antecedent interventions. Because once the behavior occurs, then there's consequence and you're actually just doing damage control. So you really want to look at the antecedent side. You want to reduce the value of the reinforcer. So if putting shoes on is difficult, then maybe you want to help the child to a certain extent, or you teach the child at a different time to put shoes on, not the time when you have to ride the school bus. Time on a Sunday, when you have plenty of time at home, you work on putting shoes on. Often, as parents, or eating a certain new food. We try to do it at meal times, and that's not the best time to do it because you definitely want your child to eat the meal. So you want to do it at a time when you have enough time to work on this in case you run into problem behavior. You want to teach an alternative, appropriate response that will replace the problem behavior. So teach the child to ask for help, or if they want a break from homework, or you line up strategies where you're prompting the child or helping the child. And then if there's a problem behavior, all you're left with, like I said, is damage control or what we call extinction as a consequence. And so now we come to extinction, which, let me tell you, as much as I think of antecedents, I can't always control that, and I'm still going to have to run extinction. So it is highly unlikely that we can control the environment 100% of the time. So in a school setting, it could be you have a class and you run into a math problem or something, but now they have to go for specials. So the environment changes. At our center, it could be the child has to go home. So it's impossible really to control the environment 100% of the time. It is also extremely difficult when implementing an extinction procedure to ensure that the problem behavior is not reinforced in any way at all. So sometimes children engage in behaviors that really make me laugh, honestly. And I have laughed, but that itself would reinforce the problem behavior. So we've had a child where we had to implement a procedure where he was just non-compliant. I've spent 3 or 4 hours standing in a room trying to avoid aggression, but asking him to do something. And eventually I'm like, just do something. I don't care what you do, just do something. And then we all start laughing. So that could reinforce the behavior. So it's really difficult to kind of not reinforce problem behavior. You want to try your best, though. Therefore, extinction alone is not going to be effective long-term in reduction of problem behavior. Again, that's what you implement when, as a consequence, you want to look at the antecedent side. Do not attempt to terminate the reinforcing contingency unless you're prepared to follow through until the problem behavior is no longer occurring. This is really, really important. I know it is difficult always to do this. Again, like I said, if your child is not putting on shoes and you really want to work on it, but the child has to go to school, that is not the best time to do it because you're not able to follow through with that. And the next time it's going to take you longer to get your child to put shoes on. And sometimes if attention is what is maintaining the behavior, even giving corrective feedback such as don't do that or stop that often maintains the behavior. So that is another common thing I try to tell my parents when they come for parent training, because here you have a child screaming and crying, and it is so, we just want to give some feedback saying, don't do that, or they're trying to hit someone, which is not socially appropriate, and a first reaction is don't do that. But if attention is the function, then saying anything is giving attention. What you would want to do is just ignore them, and if it was, say, getting them to sit in a chair, we often just point to the chair and look away. Yes, it may not always work because you may have elopement or you may have them trying to destroy property. We have to work towards that or have beanbags, and it's easier in a setting like ours. But even just saying don't do that is going to maintain the problem behavior. So when you do have extinction, when you're going to run extinction, usually there will a temporary increase in the behavior called an extinction burst. What you're going to get is intensity and variety. So you will see different topographies, possibly, like I said, crying, laughing, screaming. So that's the variety part, and you'll see intensity. It's going to get louder. Usually with an extinction burst, the problem behavior is going to increase before it decreases. And this is why often you almost feel like, I give up. I can't do this. It's because it's taking so long, your child is just screaming, you don't know how to handle this, and you're like, just let me take care of this problem right now. And at that moment when you give in is what reinforces the behavior. If the behavior is reinforced during this extinction burst, it is more likely to be severe the next time it occurs. Now, if extinction is applied without accompanying antecedent interventions that are designed to reduce the value of the reinforcer, consistent long-term reduction of problem behaviors is unlikely to occur. So again, like I said, antecedent interventions are really, really important, and not just looking at consequences, which is what we usually do. A behavior occurs and then there's a consequence, versus looking at what can we do before the behavior occurs, before we have this problem. For instance, a child who cannot communicate, they're typically going to come to you and grab your arm, or they're going to cry and scream for something. So what we want to teach them is communication. Behaviors that have been intermittently reinforced, especially over a long period of time, and are usually the behaviors that are most resistant to extinction. So a simple example, we are at the center, I'm working with a client. I typically work, say, an hour and a half. I run into a problem behavior. I've been really diligent. I'm running this procedure. I'm doing extinction. Here comes another therapist, because that's just how our center is set up. She comes in, and either without enough training or for whatever reasons, or the child has to go home, there has been the contingency changes, and the child gets to go home without completing the task. And so that behavior got reinforced. So intermittent reinforcement is going to, again, those behaviors are going to be most resistant to extinction. Extinction for problem behaviors, a procedure that is not extinction unless it produces a reduction of the behavior. So you're implementing something and you think it's extinction, like punishment, a very loosely used term. Unless there is a reduction in the problem behavior, it is not going to be extinction. So you want to measurement of the behavior must take place in order to demonstrate whether or not behavior is reducing the duration of episodes of problem behavior. So I know it's not the simplest thing to do at home, measure the behavior, because you would, taking data, you have stuff to do at home, you may have other children to take care of, but unless you're going to measure it, and of course, we as behavior analysts would be graphing it, there's no way to tell that what you have been implementing is effective if you can see the change. Okay, so at our center, I just wanted to discuss some of the things that we do to help with the initial process. So we have, usually a parent or a guardian is going to call our center and going to say, I have a child on the spectrum and I want some information. We definitely do need a medical diagnosis, because we have to prove medical necessity. So they will say, our child has had diagnosis. We'll be like, great. And we ask them to come in for an initial tour, meet with the director, see the center, see the facility, what we offer. And then if they're still interested in so the way the process works is, if you have a diagnosis, then you have certain hours that insurance is going to authorize. And we have a staff member who looks at that end of it, the insurance end of it. And they come in for an intake meeting. So at the intake meeting, we discuss the skill assessments that will be used to determine certain skill levels, including language, problem behavior, self-help, and social skills. These are just a list of the different tools we use. Again, everything is individualized. So a child who is very young, maybe at the age of 18 months, is not going to necessarily need the functional living skills assessment. We probably are going to do the VB map and the ABLES-R. And I know a lot of school districts use the VB map. We have started using the AFLs because for our older population, it is a really good tool to help teach them life skills. And then we also do the Kaufman speech practice kit, which just helps with vocalization and echoics. Based on the assessments that we do, obviously we take parent input. Parent may say, I want my child to learn how to put the pants on or brush their teeth. We obviously have to see the hours that are authorized. And then we select goals and implement the behavior reduction, the treatment plan. So our treatment plan consists of goals that are used to increase behavior, as well as the behavior reduction plan. So that's the beginning of the whole process. So parents come in. We do need authorization before we can start anything. So between the parents calling their provider, making sure how many hours they can be authorized, And then on our end, we do that, and then we determine how many hours the child, depending on what schedule the parent wants, the child is going to come to the center. And we have a treatment plan, and based on that treatment plan, we have goals on a daily basis. So our goals, we focus on communication, social skills. Yes, it is a one-on-one, but we still do social skills. So there will be me with one child and another therapist with another child, and each child has goals related to social skills. So whatever level of social skills they're going to need, we kind of teach them. Behavior reduction, almost, I think, in all my experience, they maybe have one child where we have not written a behavior reduction plan, but all our children who come to us almost always have some kind of problem behavior. Self-help skills and parent training. Skills and targets are taught earnestly throughout the session, and we use a variety of pictures, objects. We teach in the natural environment. Sessions are divided into discrete trials, and training is also done in the natural environment. So it's not all discrete trials at the table. We do discrete trials on the floor. We do maining at the table. So we really want to teach them that teaching can be done anywhere. The table does not have to be associated with work only. We do a lot of communication and requesting at the table too. So individual data sheets that track progress on targets are used and completed in each session. So every child goes home with a data sheet based on the target, and the targets are worked on throughout their session. What we also offer at our center is parent training. So parents have the opportunity to come in once a week, and we actually have goals on parent behavior, because that is something insurance is requiring to show collaboration between providers and parents. So parents come in, we have goals for parents, and we guide the parents how to work with their children at the center, and we take data on the parent behavior. We actually have to show progress on the parent training goals too. Parent training can occur in the home or community setting. If there is a need, so you come to the center and you say, I need help with this at home. If there is a situation that we cannot address at the center, then we will go out in the home and do parent training. I've actually gone into the community and helped a child work on hair cutting because he was having such a difficult time. So we first worked in the center, and then we went out in the community to work on hair cutting. Data sheets are sent home following every session, and we send progress reports to parents every 6 weeks. Within 6 months, we will do another assessment, sometimes sooner if the goals are met, and then we will meet again for a new treatment plan with updated assessments and goals. So, and that's pretty much it.